Well, so there's quite a number of trials that are either underway, planned, or have been completed for repair promoting strategies. Many of them have been relatively small studies, carried out, each one carried out in a relatively few number of centers, and they're spread throughout the world. There are studies in North America, Europe, in the Pacific region, Australia, and so forth. So probably the best way for someone with MS to find out what's being done there are a couple of websites that are useful for that. So one is clinicaltrials.gov. That's a compendium of all clinical trials that are underway. The National MS Society also helps provide information about trials that are ongoing or being planned. So those would be the two best places. And then one's care team, the neurologist, frequently will know whether something is in the works.
Given all the work that's being done, do you see any remyelination treatments on the near horizon?
Well, so I would say there's sort of two general categories of, or maybe three general categories of approaches that have been evaluated. One would be medications that stimulate the cells that make myelin. So they work through the naturally occurring myelin producing stem cells, the so-called oligodendrocyte progenitor cells. And there, people may have heard of some of these studies. So those medications include things like opicinumab, which is an antibody against LINGO. I'm not going to go into the details of what that is. Bexarotene, and then nanocrystalline gold, for example. So all of those compounds have been shown in the laboratory to affect remyelination in animal studies and laboratory studies, and have been taken to human clinical trials. And there were some promising results, but all three of those medicines had some issues. One medicine, and then another variation on that has been to test medicines that are already approved for other purposes. So an example of that would be clemastine. So some of our audience may have heard of the Rebuild trial that tested clemastine, which is Tavist. So that trial was done at University of California, San Francisco, and did show some indications of remyelination in the optic nerve. So that's the nerve that connects the eyeball to the brain, and it's a way that we frequently do preliminary studies of remyelinating strategies. So that's one category. A second category is stem cells, administering stem cells, and I think we'll talk some more about stem cells in the next segment. But that's been one of the other main approaches to trying to promote remyelination, has been to use stem cells. And then the third approach is electrical stimulation. So if you remember, I had said that a number of things interfere with remyelination. One of the things that probably interferes with it is that nerves that have been demyelinated, that have had their myelin removed, go silent. They stop conducting nerve impulses. And as a result, the brain doesn't know that they're damaged. The brain doesn't know to try to put the myelin back on that axon. So one hypothesis has been that maybe if you stimulated these silent nerves, that it might promote them being remyelinated. Sort of the greasy wheel gets the grease, the squeaky wheel gets the grease idea. And some preliminary studies have shown promise with that. So those are the sort of things that are being tested. They're all at a very early stage. The results are preliminary, but they've shown some promise. And importantly, what they've shown us is that we appear to be on the right track, and it appears that we can detect remyelination if it occurs. That's a big first step. It doesn't sound like much, but it's in fact a very important step.
Well, I'm glad that you mentioned stem cells a moment ago. When we think about regenerating what's been lost, people often think about stem cells and the possibility that stem cells could be injected or infused, and they would go to damaged areas to repair and regenerate lost myelin or nerve fibers. And it's wonderful to hear that there's research being done in that specific area. We got a question from Dawn, who wrote to tell us about a procedure for stem cell infusion that she heard about that's being done in Mexico. And she also read that there are other centers here in the US providing stem cell transplants for MS.
Right.
Is this something that Dawn should be considering?
Well, so I think the important place to start is that there are many different kinds of stem cells, and they differ in terms of where they are in the body, what their natural function is in the body, and how they might be used to treat MS, and how much we know about them. One cannot just talk about stem cells as a group. One has to talk about specific stem cell based approaches, or what we call cell-based therapies. So I believe the stem cell approach that Dawn is referring to is what's known as hematopoietic stem cell transplantation. There's a center in Mexico that's done a fair amount of that, and we'll talk about that in a minute. But that approach is mostly focusing on an anti-inflammatory benefit. The other sort of general purpose of stem cell therapies in multiple sclerosis is to promote repair. And that's a whole different kettle of fish. That's a different kind of stem cell approach with a different purpose, and it's at a different stage of what we know about it. So there are several kinds of stem cells that have been considered to try to promote repair, including remyelination in multiple sclerosis. The one would be embryonic stem cells. So those are the cells in the very early stages of the developing embryo, the fetus, the baby, and those are the stem cells that give rise ultimately to all the tissues of the body. And so there's been a lot of discussion of whether we could use embryonic stem cells to repair almost any kind of tissue damage, including damage in the nervous system. As you would expect, there are a number of sort of practical issues and ethical issues using embryonic stem cells. So there's still work being done with them, but most people have thought that there would be other kind of stem cells that might be more useful. One of the other problems with embryonic stem cells is making them do what you want, because they can turn into every kind of tissue of the body. Administering them and having them make myelin may not go as planned. So a second stem cell approach for remyelination is to transplant what I referred to before, the oligodendrocyte progenitor cells. Those are stem cells that have already partly committed themselves to being myelin-making stem cells. And that's the advantage, is that they're already part of the way to becoming the cells that we want, cells that make myelin. But they share many of the same practical and ethical issues as embryonic stem cells, because you need to obtain them from an embryo. And then the stem cell approach that we've gone the farthest with is a completely different kind of stem cell, so-called mesenchymal stem cells. This is an important category because this is the type of stem cell that has been tested the most in MS, and this is the type of stem cell that many of the freestanding stem cell clinics that people may have encountered are offering. And we'll get back to that issue in a minute. But mesenchymal stem cells are stem cells that are present in almost every tissue of the body. One of their jobs is to make so-called mesodermal tissues. So those are things like bone and cartilage and connective tissues. But their other very important job is to support the specific stem cells within each tissue that repair the tissue. So there are mesenchymal stem cells in the brain that support the oligodendrocyte progenitor cells, the myelin-forming stem cells. So there's been quite a lot of work looking at whether administering mesenchymal stem cells might promote the natural occurring repair processes. And in MS, that would be myelin repair. So those cells are very interesting. They're relatively easy to obtain. You can get them from the bone marrow or fat. You can administer them via a variety of different routes, and they tend to go where they're needed, where there's been inflammation or damage, and their natural job is to promote the repair processes that the tissue already is trying to accomplish. So that's one very important kind of stem cell therapy with several different variations on it.
The National MS Society recently made recommendations about the use of stem cell transplantation for relapsing forms of MS, specifically recommending autologous hematopoietic stem cell transplantation, or AHSCT. Can you describe this use of stem cells in AHSCT and explain how it's different than using stem cells to regenerate damaged areas of the central nervous system?
Right. So as I had said before, people need to remember that there, in the context of MS, sort of two main categories of stem cell therapies that we think about. One is the repair that I just talked about, and that's something that there's a lot of interest in. And then the other one is the one that John, that you just brought up. So that's hematopoietic stem cell transplantation. So hematopoietic stem cells are the cells that give rise to all the cells in the blood, including the immune system, the cells of the immune system. So what hematopoietic stem cell transplantation entails, or before I say that, what the purpose of hematopoietic stem cell transplantation is as a very potent anti-inflammatory therapy. So it has much the same job as the approved disease-modifying therapies, but it's an even more potent way of accomplishing that task. So what this process entails is several steps. One is what's called mobilization and harvest. So in that step, the hematopoietic stem cells are harvested from the blood. There are a small number of them circulating in the blood, and you collect them and freeze them. The second stage is what's called conditioning. So this is the administration of very high doses of chemotherapy to kill the immune system, to eliminate the MS-producing abnormal immune system. So that's the part of this sequence that's actually the MS therapy, but it's also the part of this sequence that has all the greatest risk for complications. So the chemotherapy has side effects. When you eradicate the immune system, there's the potential for infection, and sometimes the other aspects of the bone marrow are also damaged, so people can get anemia or bleeding. And so the third stage of the whole procedure is to re-administer the hematopoietic stem cells that you collected at the beginning to shorten that period where all the blood cells are missing, and to lessen the potential complications, and to speed up recovery. And then the idea is that as the immune system recovers, it will then function normally. And in fact, there have been quite a few studies of hematopoietic stem cell transplantation in MS. All of them had individually some shortcomings, but when you put them all together, this approach appears to have very potent efficacy. It works really well. It, in many cases, literally stops the ongoing inflammation. And it has very durable efficacy, meaning that the benefit lasts for 5-10 years without any additional therapy. Now, you may be asking, well, why don't we do that for everybody? Well, it's because it does have a lot of risks, and it is a very expensive procedure. It costs about $150,000. But those costs are all up front. So the risks are mostly at the time of the transplant, and the costs are mostly at the time of transplant. So that was the basis of the recommendation that recently was put out by the National MS Society, and there have been some other position statements that have said similar things, which is that for people with very active multiple sclerosis who have not achieved sufficient control with the available medications, that transplant is a reasonable option.
I was about to ask you who would be a good candidate, and I think
Right.
you just shared that. So thank you for clarifying.
I think there's one other point to make. So the people that are probably the best candidates are people that are relatively young. Exactly the cutoff isn't clear, but maybe 50 years of age or less. People who have very active disease, meaning they're having continued relapses or active MRIs, and people that have not responded sufficiently to medications. And the reason for those criteria is that those are the people that are most likely to benefit, and those are the people for whom the risk is more reasonable. As people get older, have much more severe MS, who have not had recent relapses, they're less likely to benefit, unfortunately, and also more likely to have complications. So that's the reason for those criteria. Now, what we don't, the recommendations that recently were put out specifically say that transplant's a reasonable option for people that have failed other therapies and really who have very few other options. What's a very important question is whether transplant is a reasonable alternative to our currently available highly effective therapies. And so there are a number of, there's I think 5 randomized studies now being conducted to address that question, to ask whether transplant is a good alternative to some of our infusion therapies. So, for example, so that's where that stands. And so I think the transplant field, particularly hematopoietic stem cell transplant, is now starting to make some very real progress.
We heard from Rebecca, who's wondering whether autologous hematopoietic stem cell transplantation affects fertility. What are the risks of this type of stem cell transplant?
Yeah, so I sort of lumped together the many potential complications, and the chemotherapy that's involved with hematopoietic stem cell transplant does frequently affect fertility, not only in women, but also in men. So that's one of the considerations. If someone is young and still considering having a family, but is also considering hematopoietic stem cell transplant, then they may want to take some steps, for example, to preserve some eggs or sperm so that they could have a family later on after the procedure. The other part of it is that you have to go back and get all your immunizations again, for example. So there are a lot of potential issues with transplant. So it's something that we're interested in. We're still refining how to best do it, but it's not something for everybody at this stage.
Aside from the use of stem cells, are there any other types of regenerative therapies that are currently under study?
Well, I talked about a number of the medications and the electrical stimulation. So those would be sort of the main areas. I think the other important point to make is that people with MS can also take control of this themselves. People may have heard from their care teams about the importance of diet, to eat a healthy diet, the importance of managing their other medical conditions, so-called comorbidities. They may have been advised to stop smoking. The reasons for that is not just because all those things are healthier, but for MS in particular, they're important because they help the body withstand the MS process, so it limits the damage that MS causes. And it also is important for the natural repair that the body is already trying to accomplish. So good nutrition, exercise, treating your high blood pressure, your diabetes, not smoking, all those things are something that someone with MS can do themselves to promote remyelination.
I'm glad you mentioned exercise. Janice wrote in and shared that she read that there's at least some evidence presented that people who exercise actually increase their brain volume. Is this true?
Yes, so exercise has a lot of benefits in chronic diseases, including in multiple sclerosis. It first of all, it optimizes cardiac function and muscle function and flexibility and so forth. But secondly, it promotes both repair and promotes what we call neuroplasticity. So two of the ways that the nervous system tries to compensate for damage is to repair the damage. So in the case of MS, that's remyelination. But the other way it tries to compensate for the damage is to recruit undamaged nerves to take over the job of the nerves that have been lost. So it's sort of like when you have I don't know, an office with a number of office workers and some of them are out sick, you recruit other people, you assign other people to do the job of the people that are out sick. Well, the nervous system does the same thing. And exercise promotes both repair and neuroplasticity. And one of the ways you can measure that, besides improved function, is by less brain volume loss, less shrinkage of the brain, and in some cases, recovery of brain volume. So yes, it has real benefits.
So what type of exercise is needed to produce these kinds of outcomes?
Well, so that's something that's getting a lot of study. We think the optimal exercise regimen in MS is something that combines flexibility, so stretching and things like that, that combines strengthening. So that would be isometric exercises, lifting weights. It doesn't have to be massive weightlifting, but something that involves some resistance, and then cardiovascular training, so something that gets your heart rate up. And the combination of all three of those works better than any of them by itself. Now, people with MS may have neurologic problems, so sometimes the exercise regimen has to be adapted, and that's where physical therapists can be very helpful in helping develop an exercise regimen that's tailored for the person with MS.
Well, Dr. Cohen, I want to thank you for helping us better understand remyelination and regeneration research. Before we continue our conversation, I want to welcome those of you who have continued to join us on GoToWebinar, Facebook Live, and YouTube Live. Please let us know what's on your mind. Post your comments and questions in Facebook and YouTube, or type them into the questions box if you joined us on GoToWebinar. Our Ask an MS Expert live event takes place at this same time every Friday, so please make sure that everyone knows about it by sharing news about the webcast with your family and your friends. We've been talking about the current research on remyelination and regeneration in MS with neurologist Dr. Jeffrey Cohen, the director of the Cleveland Clinic's Mellen Center for Multiple Sclerosis Treatment and Research. With COVID-19 numbers back on the rise, I'd like to shift gears and focus on what experts are continuing to learn about COVID-19 and its impact on people living with MS. Dr. Cohen, a few weeks ago, you were part of an expert panel of MS neurologists and researchers from the MS International Federation's member organizations that published an update on how COVID-19 affects people with MS and provided guidance on high-risk individuals, disease-modifying therapies, stem cell treatment, and vaccines. So based on these recently published guidelines, does having MS make someone more vulnerable to contracting COVID-19?
Well, I knew we couldn't get through a video conference without talking about COVID-19. So those are all very important questions. And there's been quite a few efforts try to gather the data necessary to try to address some of those questions. And so there's several what are called registries where people are contributing information about people with MS and their experience with COVID-19. So there still are some unanswered questions, and we're still learning about COVID-19 and multiple sclerosis, but there is some information that's already emerging. So one point that's, I think, very reassuring is that having MS per se and our MS medications in general as a group don't appear to make people more susceptible to catching COVID-19 and don't make people at higher risk for severe COVID-19 or complications from it. Now, there are some qualifications. So for medicines as a group, they don't appear to increase the risk, but there may be some differences between the medications. All of the medications work by affecting the immune system, and they do it via different mechanisms, and they have different durations of how long they have those effects. And there's been some indication in some studies that the CD19, the anti-CD20 treatments, so that would be treatments such as ocrelizumab, Rituxan or rituximab, Kesimpta, ofatumumab, may increase the risk for more severe COVID-19. But I would say a couple of important points are that some studies, but not others, have indicated that. So it's not been a consistent result. The increased risk has been small, and the overall risk of a severe outcome of COVID-19 has been very modest. So in general, our approach at the Mellen Center has been to not make major changes in how we're treating multiple sclerosis in terms of medication. So we're, for the most part, not delaying starting treatment, and for the most part, not stopping or altering treatment that someone's already on. And if we need to change therapy, we're mostly changing therapy as we otherwise would have. Although we do, of course, individualize it to each patient's situation.
Are there some key recommendations you can share that might help people reduce the risk of contracting COVID-19?
Right. So one of the things we've learned from those registry studies that I referred to is that for the most part, the risk factors for getting COVID-19 and for having a severe outcome from COVID-19 among people with MS are the same risk factors as for everybody else. So they include things like being a man, that in this case, that's a disadvantage, older age, obesity, having obesity or other medical illnesses, comorbidities, exposure to people with COVID-19, having less access to healthcare, and probably some groups such as African Americans and maybe Hispanics. So those seem to be the main risk factors for everybody, including for people with MS. And then for people with MS, some things that are more specific to MS are having a higher level of disability, and, as I said, possibly treatment with some of the certain disease-modifying therapies. So those are the risk factors. And then the approaches that people should take to try to lessen their risk from COVID-19 are some things that they should do and some things that they should not do. So among things they should do are the things that we've been hearing about. So they should avoid exposure to people known to have COVID-19. They should social distance. So that means at least 6 feet apart or more. They should avoid enclosed spaces, particularly indoor spaces where ventilation is not adequate. And they should wear a mask not only do we wear masks to protect other people so we don't spread our germs to them, but there are now a number of indications that wearing a mask also protects you. It lowers your risk of exposure, and if you are exposed, it lessens the amount of exposure. Frequent hand washing, avoiding touching your face and eyes.
Dr. Cohen, I think we may have lost your audio for a moment.
Oh, okay. Can you hear me now? How about now? Can you hear me?
I can, yes.
What was the last thing that you heard me say?
You were just getting into the most recent comments you made regarding the things that we've been all hearing about that people can do.
Well, they're avoid enclosed spaces, social distancing, hand washing, wear a mask, avoid touching your face and eyes, and also stay active and healthy and get a flu vaccine. And things that you should not do, particularly if you have MS, is avoid doctor visits or visits with your healthcare provider. If needed, they can be done virtually. You should not stop or avoid disease treatment without discussing that with your care team. And you should not stop things like physical therapy or health psychology or those sorts of things. What we're learning is that yes, people with MS are at risk for getting COVID-19 like all of us, but MS is a more immediate risk for most people with MS.
A few moments ago, we were talking about hematopoietic stem cell therapy for relapsing MS. Is there any advice for people who have recently undergone or are planning to undergo AHSCT?
Well, part of that procedure is that if you remember, there's a period after the conditioning where and after the transplant where the immune system and the rest of the blood forming cells have not yet recovered. So during that period, people are more susceptible to infection. So usually people are in the hospital for the first several weeks, maybe a month after that, and then they're in isolation at home for another month or two. So if someone's just undergone hematopoietic stem cell transplant, they may want to prolong that isolation period. Generally, the transplant units are very strict. So they're pretty good at limiting infections, but it's once you get out of the hospital that you have to be careful. And then I guess the other point I would make is that people should consider whether a transplant is really necessary during this somewhat uncertain time.
Are there any special considerations for people with MS regarding the use of steroids during the pandemic?
So there have been some indications that some people with MS that had more severe outcomes from COVID-19 had recently received a course of steroids. So I don't think it's necessary to avoid steroids if one needs it, but that's the key phrase, is that I would not administer them unless they're needed. So if people are having a relapse and they need steroids, then I would proceed, and they just need to be more careful about not getting exposed to COVID-19. But I would not, people should not use steroids capriciously.
You actually answered my next question a few moments ago, answering a different question, but we get so many questions on this. It's the question that pops up over and over again this time of year. So I'm going to circle back to it one more time. Should people with MS get a flu vaccine?
The short answer is yes. It's been, one of the worries is always that a vaccine might activate MS. That's been looked at several times, and that thankfully appears not to be the case. The flu is serious, and the flu during a COVID-19 pandemic is also serious. So we're encouraging our people that we follow with MS to get a flu vaccine.
I'm wondering whether the updated MSIF guidelines include any recommendations about a potential COVID-19 vaccine.
Right. So we're all very anxiously awaiting the arrival of a COVID-19 vaccine. So it's at this point, we don't know when that's going to happen. and we don't know the specifics of the vaccine. In fact, there'll probably be several vaccines. So right now, it's hard to make recommendations specifically related to a COVID-19 vaccine, but once one becomes available, we'll know more about it and we will make further recommendations. There is a consideration that's gotten a lot of discussion about whether some of the MS disease therapies might interfere with someone's ability to to generate immunity after getting COVID-19 or after getting a COVID-19 vaccine. That's something that will have to get examined. But right now, we're awaiting the vaccine and forging ahead with MS therapy as we would otherwise.
We've covered an awful lot of important information today, so I'm hoping you'll share the top 3 takeaway messages that you'd like our audience to keep in mind.
So I'm going to emphasize 3 things. One is that there are a variety of approaches to remyelination that are under investigation. These include stem cell approaches, medications, electrical stimulation, and so forth. There are a lot of technical hurdles that we're going to have to overcome before we solve that problem. So that's one. But I want to reassure the audience that there's a lot of attention being put to developing repair strategies. The second key take home is that there are many kinds of stem cell therapies. They have different purposes. They have different issues. One cannot just talk about stem cells in general. One has to talk about specific types of stem cell therapy. The stem cell approach that we probably know the most about is hematopoietic stem cell transplantation. It's probably a very useful option for some people with MS, but it's not at the moment something that we're advising in general. And then the third take-home message is that I would say in a nutshell that for most people with MS, their MS is a bigger risk than COVID-19. But of course, we all need to be careful about COVID-19.
Well, thank you, Dr. Cohen, for sharing your expertise on these topics. Now I'd like to continue taking more of the questions that our audience has for you. This is one that you've also started to answer, asked a little differently. Michelle has reached out and said she'd like to hear about outcomes of stem cell therapy in people aged 50 and over, and for those whose lesions first presented in the spinal cord. What can you tell us about the efficacy of stem cell transplants in these populations?
Right, so maybe I'll do those in reverse order. So at this point, at least hematopoietic stem cell transplantation, the location of the lesions is not so key. We think that it'll be effective in preventing new lesions in any of the locations that can be involved in MS. The first part of the question sort of speaks to who is most likely to benefit and who's at more risk for complications from hematopoietic stem cell transplantation. And that's where age becomes important, because older people are less likely to benefit. They, as a group, tend to have less of the aspect of MS that approach treats, which is the frequent development of new inflammatory lesions. And because they're older and tend to have a greater number of other illnesses, they're at greater risk for complications from the procedure. So that's why the ongoing trials, for example, have limited the upper age limit to less than 50 years of age. And that's why, in general, we're not recommending that approach for older people with more severe progressive disability. But as we learn more about the procedure, we may be able to fine-tune that. I want to reassure people that these are not arbitrary rules. They're what we've learned from our prior experience.
Now, the person who submitted this question didn't submit their name, but I think many of our listeners can relate. They wrote, "My husband was diagnosed with MS in April and his doctor is not putting him on medication because of COVID-19. Is this okay? Now, we know you can't comment specifically on whether this individual should be started on a disease-modifying therapy, but Dr. Cohen, can you speak to the safety of starting a new disease-modifying therapy during COVID-19?
Well, I can say that our general approach at the Mellen MS Center has been to start therapy once we're sure of the diagnosis in most people, and we've continued to do that even during the pandemic. Now, we do, of course, consider aspects of each individual, how much they need to be on therapy, whether they have other illnesses or other considerations that might make one therapy advantageous over another, whether they have other illnesses that make some therapies more risky than others, and also whether they have other factors that might affect their risk of COVID-19. So we take all those things into account, but in general, for most people, we are still advising beginning therapy after the diagnosis is made.
Well, while you and I have been talking, my partner in crime, Julie Fiel, has actually been in the background fielding additional questions. And welcome, Julie. Have you got some questions? I think we have time for a couple.
We did get lots of questions. Dr. Cohen, people really loving this information that you're sharing. We heard from several people, Helen and Phyllis in particular, have questions about, they heard you talking about how exercise can help repair some damage in the central nervous system. And they're curious about the role that diet might play, and if there's any evidence that remyelination can occur based on changes to diet or even supplements, like they specifically asked about vitamin D or B12.
Yeah, so for the most part, I would say the evidence supporting diet directly and specific diets and specific supplements is pretty thin. So in terms of remyelination, so our general recommendation has been a balanced diet in terms of diet, sort of a balanced diet. For us, we think that a Mediterranean diet is a good compromise between being nutritious and something that people can follow. It has other benefits in terms of heart health and preventing stroke, but it also is useful, we think, for MS. And then in terms of supplements, in general, we don't think that the deficiency of certain things is, in most people, one of the main obstacles to remyelination. So just providing more myelin components, as it were, doesn't seem to be as useful. Now, of course, if someone is deficient in certain vitamins like vitamin D or B12 would be good examples, that needs to be corrected. But just giving extra vitamin B12 doesn't seem to help. Your body just gets rid of the excess if it doesn't need it.
Well, this next question is from Cheryl, and it touches on something that you just alluded to. And she's really trying to get back at the heart at, so if we repair myelin, does that mean we'll return to full functioning? Or, what's the goal of myelin repair?
Well, so yes, I probably should have said that. So myelin repair is to serve two purposes. One is, in the short run, it's to restore function in nerves that are not working. They're short-circuiting because they've lost their insulation. So one purpose is to restore function. Now, whether it can return it to normal sort of depends on whether all the nerves could be repaired or not. I think at the moment that we're not likely to be able to accomplish that in the short run, but certainly to restore function is one of our goals. The other goal that may not have been so apparent in my comments was to prevent worsening, because we think one of the mechanisms that leads to progression, the gradual worsening that many people with MS experience, is that nerves that have had their myelin damaged, even if they survive the initial insult, the initial attack, then deteriorate later over time. They degenerate over time, and it's because they've lost all the benefits that myelin provides to them. So one of the other goals for remyelination would be to prevent worsening in the future.
Oh, that's very helpful. And unfortunately, I think that's all the time we have for questions today. So thank you so much, Dr. Cohen. I'm going to turn things back to John.
All right. Well, thank you, everybody, for listening.
Thanks, Julie. Thanks to all of you who submitted your questions. And I'll also thank Dr. Cohen for being with us today and sharing some important insights on remyelination, stem cell therapy, and the impact of COVID-19 on people living with MS. I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you, and these are resources that you can count on to be current and credible. I want to remind you that if you're unable to get your questions answered today, the National MS Society's MS Navigator team is your best partner in answering your questions and connecting you to the very best information and resources. It's also worth mentioning that health insurance open enrollment season has begun, and Medicare open enrollment runs through December 7th. MS Navigators want you to know that they have a lot of great resources and tools for anyone looking at their 2021 health insurance options. There's even a special team that's setting up appointments for Medicare beneficiaries during open enrollment to help ensure that your 2021 coverage is what you need it to be. You can contact an MS Navigator by phone, email, or live chat through the National MS Society's website. For more information on resources and on remyelination and regeneration research in MS, please go to the Society's website at nationalmssociety.org and use the search term research. I'd also like to acknowledge that we're in the midst of an emotionally difficult time for so many people. And I want to make sure that you're aware that the National Suicide Prevention Lifeline is available 24 hours a day, 7 days a week. They offer free and confidential support for people in distress, as well as suicide prevention and crisis resources for you or your loved ones. You can reach them by calling 1-800-273-TALK. That's 800-273-8255. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. With vital funding from supporters like you, the National MS Society will work to ensure that resources and programs like today's are available and that the MS research community rebounds quickly from COVID-19, so the progress and momentum toward finding a cure continues. As you're able, please make a donation to the Society's COVID-19 Response Fund by texting the word GIVE to 68686, and you'll get a link right to the MS Society's COVID-19 Response Fund webpage. I hope you'll consider contributing today. You can connect with the National MS Society on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And please make sure you're on the Society's mailing list so you'll continue to receive the latest information on MS research and updates on upcoming programs like this one. I'd like to thank Dr. Jeffrey Cohen for joining us today, and I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webinar is going to be available for your review on the Society's website at nationalmssociety.org/MSexpert. And now we have a favor to ask each of you. Getting your feedback on today's webinar is important. So you'll see a survey pop up in a moment when we close out the webinar. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute and fill it out. On behalf of Dr. Jeffrey Cohen and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.